Hello, my name is Dan Bruns. I am a clinical psychologist, and what follows is a workshop I conducted at the 2009 American Psychological Association National Convention. The topic of this workshop was the psychological assessment of patients suffering from chronic pain and ones who may be considered for undergoing spinal surgical interventions. This was an advanced workshop and deals with a number of important matters on a fairly in-depth basis. The goal of this workshop was first of all to review both relevant science and guidelines, but beyond that, to talk about the complex clinical questions that often arise and to offer suggestions about how they might be addressed. This workshop used a case history format, although using the term case history is something of a misnomer because it's actually a composite case. I think case histories are wonderful teaching tools. The problem, though, is of course a matter of confidentiality. So, in the attempt to walk through a very difficult case, I've used a composite case history, which is derived from actual patients, but does not represent any actual single patient that I've seen. So while I've taken a few liberties here, I think it is very important to go beyond thinking about randomized controlled trials and to think about psychological evaluations in terms of the plight of the individual patient and what they may be going through and how to assess that and what to do about it. Just a bit about myself first. I've been in independent practice for 23 years, treating patients with various sorts of medical problems, but mostly chronic pain. The cases I work with are generally pretty complex, and about 60% of my caseload over the years has been in litigation over their health care. So there is always a forensic element looming in the background, and of the 40% of the people I see who don't have an attorney, I generally behave as if they might someday, because you never know. Outside of my actual practice over the years, I've served on 8 evidence-based medicine task forces and advisory panels. I say evidence-based medicine here as it's not really been within the psychological world, but rather within the medical world that I've served in this capacity. Additionally, I'm also a psychological test author. I need to point out that being a test author gives me a conflict of interest, and in today's case, I'll be discussing one of my tests because that's the test I use. Even so, please keep in mind that that gives me a conflict of interest. I want to start out today by considering one important statistic. That's from a study done just this year by Wisniewski and Rush, who looked at almost 3,000 patients with depression. It was interesting that they found that of these patients, only 22% met the typical entry criteria for phase 3 clinical trials. I think this statistic really underscores a phenomena that often creates a gap between research and practice. In my own practice, I generally don't see the easy patients, and so I may not see any of those 22%. People get referred to me because they're complicated. As a result, there has not been as much research on these sorts of complex cases. The STAR-D studies on depression are attempting to do this, which I think is really laudable. What I want to do today, though, is to try to take a very complex case and to try as best I can to show how scientific findings can be adapted and applied to these kinds of cases. My hope is that to some small extent I can contribute to closing the gap between research and practice. So let's go to an overview of what I'll be talking about today. First of all, I'll provide an introduction to the case, Secondly, I'll be discussing general guidelines and also biopsychosocial laws that apply. I'll be talking about conceptualizing pain, about psychological assessments of pain, treatment, forensic complications, and conclusions. In a number of these areas, I'll be going into considerable detail, and so I hope you will find it interesting. Now, I have a number of handouts that you might want to examine, and if you wish to download them, you can go to www.healthpsych.com/APA2009.html. I will show this again at the end as a reminder if you want more materials in this presentation. This is a case history about a woman named Sarah. She was a 39-year-old woman who was a white-collar employee at a company. She'd been there for 8 years when she was injured in a slip and fall. She was walking between buildings, stepped on some ice, slipped, fell. She twisted her ankle, landed on her left hip, and wrenched her back. Sarah laid there for a moment before she was able to get up, in a good deal of pain, walked in and reported the accident. Her employer, though, reacted initially with some skepticism because nobody had seen her slip and fall. And so she was referred to her personal physician. So she went to her personal physician, who listened to her story and said, "Now this is a work injury. You need to go to your work comp doctor." And so she was referred there. The company initially resisted this referral, but eventually relented, and her work comp claim was provisionally accepted by her work comp payer. Even so, she was told that her claim was being investigated. This bothered her because it felt accusatory, but nevertheless she went on to see her doctor and felt that she was treated fine. Some of you may not be familiar with the workers' compensation insurance system and how it functions differently. Most people progress through the work comp system normally, but some people don't. Because for the dysfunctional person, the work comp system offers a lot of incentives to not get well. So for a dysfunctional system with a work injury, one, you don't have to go to work, which is especially good if you hate your job. You get disability pay, so you get paid despite being at home. You can get free legal narcotics, free massages, and if you don't get better, you get a bonus at the end in terms of a settlement, plus sometimes maintenance care, including a lifetime of free narcotics. For some people, consciously or unconsciously, this becomes a big incentive to behave dysfunctionally. And because of that, many patients within the workers' compensation system are treated with suspicion. But let's move on to the medical assessment. Ankle x-rays, normal. Lumbar x-rays, though, show degenerative disc disease from L3 to S1. As time went on, the ankle strain resolved quickly. PT and anti-inflammatory medications were used for low back pain, and the low back pain improved after about 2 months, although Sarah went back to work without restrictions. About 2 years later, though, Sarah had a second injury. This was a rather innocuous event, where she had bent over to pick up a small object off the floor and felt a sudden onset of pain in her low back, which went down to her left leg. She returned to her work comp doctor, but this time conservative treatment failed. Sarah was next referred for an MRI, which might have looked something like this. Here you can see the white stripe running vertically as a spinal cord, and you can see how it's being compressed by a bulging disc. In cases like this, where there's nerve compression, surgery is indicated, and Sarah underwent a discectomy and laminectomy. Now, if you're not familiar with it, a discectomy is a procedure where the surgeon goes in and actually surgically removes a part of the disc that is pushing out and pressing against the spinal column or the nerve root. Additionally, she underwent a laminectomy, which involves removal of the dorsal part of the vertebra. So basically, normally the vertebra is the bone that has the spinal cord going through it. So if the vertebra were a car and you cut off the top, you would make it into a convertible. This further decompresses the spinal cord and nerve roots. Unfortunately, following this, there were severe complications. First of all, She had a post-surgical staph infection, was hospitalized for this. Next, after being bedridden for a long time with infection, she developed deep vein thrombosis, which are blood clots in her legs. And during this time, she became depressed. She was referred for a second surgical opinion and also for a psychological consult as well. So, things were just going from bad to worse. The surgical opinion suggested the possibility of a lumbar fusion, which could occur in a couple different forms. One with hardware, as seen in the picture on the left, or the other with an interbody cage, as seen on the right. Now, the problem was the ongoing infection had not yet resolved, and this precluded the possibility of surgery at that time. So the other options were interdisciplinary treatment, physical therapy, medication, interventional procedures, and psychological treatment. It is within this context that I saw her. I want to go on now to discuss the assessment and treatment of chronic pain. I suspect you've all heard of the gate control theory of pain. This theory goes back about 45 years to the Melzack and Wall's classic study of pain mechanisms. This article hypothesized that pain was not a simple sensory experience, but rather was influenced by stress, emotion, and cognition, and that these variables could open and close the so-called pain gate, and thus greatly influence the perception of pain. What you may not be aware of is that after another 40 years or so of thinking about the nature of pain, that Melzack has come up with a new theory called the Neuromatrix theory of pain. This is published in two papers, one in 2001 and one in 2005. In Neuromatrix theory, pain is believed to be the consequence of the output of a widely distributed brain neural network rather than a direct response to sensory input. The Neuromatrix model looks something like this. There are multiple inputs to pain, which these can be sensory inputs, affective reactions, and cognitive evaluations of the pain. All of these inputs go into what Melzack calls the body self neuromatrix, where the information is processed, and from this come several outputs. This includes pain perception, what he calls action programs, and stress regulation. Neuromatrix theory is Melzack's attempt to try to tie together literally thousands of research studies over the last several decades. The result of all this research, though, is that there's strong evidence that chronic pain is a biopsychosocial phenomenon. And because of this, evidence-based treatment guidelines have begun to adopt the biopsychosocial model. And beyond this, the biopsychosocial model has now begun to have an impact on the law. In Sarah's case, there were three major treatment guidelines that were involved. First of all was the ACOEM guidelines. These are from the American College of Occupational Environmental Medicine. This is the National Society of Physicians who treat workers' compensation patients. Now, these are the guidelines of that profession. Secondly are the Colorado Medical Treatment Guidelines, which were developed by the Division of Workers' Compensation. These are evidence-based guidelines which are also part of state law. Lastly, the ODG was a guideline also involved. This is commonly used by payers. ODG stands for Official Disability Guidelines, and these are often used by payers for utilization review. Now, interestingly, the ODG borrows heavily from the Colorado Psychological Guidelines. All three of these guidelines, ACOEM, the Colorado Treatment Guidelines, and the Official Disability Guidelines, all have a biopsychosocial orientation, both to conceptualizing injury and to treatment approach. Additionally, all of them recommend or require psych evals for pain and select invasive procedures. Now, for those of you who feel the term biopsychosocial isn't cumbersome enough, I want to introduce an even more complex compound word, biopsychosocial legal. As I just noted, the Colorado Medical Treatment Guidelines have become part of the state law, and in a number of jurisdictions, evidence-based treatment guidelines have gone through a legislative process and been adopted into laws and regulations. I presented on this topic yesterday, and I don't know if any of you were there for it, but I want to just touch very briefly on what is happening. There are a number of jurisdictions where biopsychosocial guidelines have gained legal status. As you can see here, there are now 7 states and 1 Canadian province where this is happening. So what is the impact of implementing biopsychosocial guidelines? This is from an article which is currently under review on the implication of these guidelines. First of all, by way of context, we can see from 1998 to 2004, there's a 27% increase in the medical consumer price index, 113% increase in the rate of spinal fusions, 197% increase in interventional treatments, and yet in Colorado during the same period, there is a 24% decrease in medical costs. This makes Colorado one of the rare cases where over the last decade we have had medical deflation. The effect of the Colorado guidelines has been complex, and I don't want to oversimplify it, but the fact that you can introduce evidence-based medical guidelines which are based on a biopsychosocial model and reduce costs when everything else in medicine is going up, I think is pretty important to note. We're hoping this article will come out in an upcoming version of a new journal called Psychological Injury and Law. Let's go back to Sarah now. The initial interview. During the first session, I dealt with a question that I often deal with patients of this type. They say, why am I seeing you? The pain is not in my head. Even though the science supports a biopsychosocial model, that's not the way patients think coming in. Now, Melzack's model is quite comprehensive, but it's so complex as to be of not much use in actually talking to patients. And the real risk is initially that the message can get lost in the translation about why the patient is seeing you. The first thing I do when meeting with a patient is to try to explain why they're seeing me and try to introduce them in a simple way to the biopsychosocial nature of pain. One of the things I've done over the years is developed handouts and other materials I give to patients to start with some initial education. And here's an example. I call it the pain onion. As you can see here on the top, it says, like an onion, pain has layers. And so I explained to her how part of her pain may have been due to tissue damage, which is the bullseye in the onion here, how there's neuropathic pain from nerve damage, muscular bracing pain just from all of her tight muscles, and that insomnia, exhaustion, negative thinking all make it worse. We also talk about an overview of the treatment process and about how nobody is trying to tell her that she's crazy or making all this up. Again, remember, she'd already been investigated for her pain. And in the workers' compensation field, many patients are suspicious of psychologists. So the first step is trying to set her at ease and help understand what we're going to do and how this is intended to help her. This brings us to the next question. How do you do the initial assessment of a patient with chronic pain? In the guidelines that I worked on, the Meyer study had a substantial impact. This was a huge review study which looked at 125 meta-analyses and 800 studies, all looking at psychological and medical diagnostic instruments. Basically what it concluded is the best psychological tests are comparable to the best medical tests in their ability to diagnose and predict outcome. It was studies like this that persuaded all the major medical treatment guidelines to begin requiring psychological diagnostics prior to invasive procedures of many types. So an assessment, what do you look at? At the present time, using evidence-based medicine principles, there is only one high-quality study about the criteria for presurgical psychological assessments for patients with spinal injuries. And this is one conducted by Boer and colleagues in 2006. They used a strict criteria for inclusion that ended up selecting 11 studies. From this, they identified 9 variables for which there was consistent evidence of impact on surgical outcome. And these variables are pain, functioning, depression, anxiety, somatization, job dissatisfaction, passive coping, time off of work, and level of education. If we step back a bit, the Boer study has significant strengths and weaknesses. As a strength, it is the first systematic review of the literature which has identified consistent trends about psychosocial predictors. It also has some weaknesses. If you go back and recall the STAR-D study that I mentioned at the outset about how only 22% of patients meet the criteria for law of studies, that creates a filter, and consequently, there really are no surgical outcome studies that look at severe psychopathology. There are no studies looking at performing elective surgery on people who are manic, psychotic, actively abusing methamphetamines, imminently suicidal, and so consequently, there's a huge gap in the literature. It was because of this that after reviewing all this information, the ACOEM guidelines suggested that for pre-surgical psychological assessments, the Boer criteria should be considered, but there also needed to be a more comprehensive screening for psychopathology. And the next thing to consider is what types of tests do we use? All 3 of these guidelines, the ACOEM guidelines, the Colorado guidelines, and ODG, all comment on specific psychological tests. Now, as I mentioned before, I worked on both the Colorado guidelines and the ACOEM guidelines, and part of my role there was to help review psychological tests to determine their appropriateness. The Colorado guidelines on psych tests was first released in 2001 and reviews commonly used tests. This guideline has turned out to be fairly influential. It's been adopted by the official disability guidelines, and it's also recently been adopted as a state regulation in California and Oklahoma as well. Now, the Colorado guidelines on psych testing are also used by Texas and Kansas. Their legal status here is a bit murky, and it would probably take an attorney to explain it, but suffice it to say, it's one of the documents used in Texas and Kansas. The ACOEM guidelines, in contrast, also has their own review of psychological tests, which is similar to Colorado. And this is, of course, the standard used for occupational medicine physicians who treat workers' compensation patients. So while both the ACOEM standards and the ODG are national guidelines, various states have also adopted documents about psychological testing as well. One of the dilemmas in chronic pain assessment is there is a profusion of small screening devices which are non-standardized. After much debate, it was the consensus of the ACOEM panel that they would adopt APA's position, which was only standardized psychological tests should be used for clinical assessment. This was adopted from a work that was co-authored by the APA called the Standards for Educational and Psychological Testing, which is one of those reference works that we hear about but seldom read, but it also adopts a position that only standardized tests should be used for clinical assessment. ACOEM also adapted its definition of standardized tests from the APA, knowing that a standardized test is characterized by having a manual, having evidence of validity and reliability, and also having norms and standardized scores. ACOEM made a particular point of this because a lot of what is done in the field is based on poor science. Pain is now regarded by many as the 5th vital sign. So you have temperature, blood pressure, pulse, respiration, and pain. But pain is different because it's the only vital sign which is a subjective experience. And this makes assessment of it much more difficult. Now, at first blush, this seems really simple. On a scale of 1 to 10, rate your pain. What could be simpler? It turns out this is far more complicated than it appears, especially when you're trying to adapt this to the clinical setting. So here on the screen, you can see we have a 1 to 10 scale. Looks pretty straightforward, but wait a minute. So what's a 10? Pain so bad you want to die? Worst pain you can imagine? I mean, what is a 10? And oh, by the way, is it 1 to 10 or 0 to 10? Should there be a 0 on here, or is it a 1 to 10 scale? If you ask physicians in the field, most people say on a scale of 1 to 10, not 0 to 10. So what is it? Another question is this, is if you have a body temperature of 102, well, that's high. Blood pressure of 152 over 110, that's high. Pain of 5, is that high? What's normal? The problem in pain assessment is there's a lot of measures which are standard in the field, but they're not standardized. They do not meet the criteria for a standardized tool, either using the APA's criteria or ACOEM's criteria. In fact, when we began studying this, we found in fact that there are an enormous number of variations of pain scales. We collected them from a variety of sources, and surprisingly, we never found two that were the same. The ACOEM evidence-based panel concluded the following about the 0 to 10 pain scale. Let me just read this. Recommended by JACO. Complete lack of standardization with literally thousands of variations. No defined instructions with regard to what constitutes a 10, e.g. worst pain you can imagine versus pain so bad you want to die. Time frame, pain right now versus typical pain today or last week. Location, overall pain versus pain in one body site. Scaling, e.g. 1 to 10, 0 to 10, 1 to 100. I want to spend a few minutes now talking about some of my own research in this area, which is about the clinical assessment of injured patients. I have been working with Pearson assessments in test development for about 16 years now. It's been a great experience as they have some very bright people with a lot of expertise in psychometrics, and we've spent many years wrestling with these issues. I want to talk for a little bit about what we found and then apply this to Sarah and her assessment. There are a lot of basic fallacies in pain assessment that are rarely considered. One is that basic rating scales assume that pain is one thing in one place. Well, that's not true. Another is that people apply numbers in the same way to their pain, which isn't true. And beyond this, just the idea that the 1 to 10 rating scale is actually one thing, which, as we've seen, is not true. Now, the 0 to 10 scale assumes that pain can be described by one number. Now, here's a pain drawing, which would be consistent with that. A person who says his whole body hurts the same way. So if he said my pain is a 10, you can say, okay, his whole body is uniformly a 10. But that's not how it works. I mean, looking at this, it seems kind of silly, but the reality is more like this. Pain is distributed in specific locations across the body and may have different intensities in different places. When we were struggling with how to assess pain, we had the idea of trying to create a synthesis of a rating scale and a pain drawing. This is one of the things we came up with. This is from an unpublished rating scale, which looks at pain in 10 different body areas. And if we look under the column here, momentary pain, that's their pain right now, kind of like what a 0 to 10 pain scale might say, their overall pain. And their pain complaints looks at 10 different body areas. We can see this person has pain in their mid-back, low back, legs or feet. And that's kind of what they're saying in the pain drawing on the left. So we can see a correspondence between how they respond in the drawing and how they respond on the questionnaire. Similarly, if we look at the second case, where a patient who reports feeling pain everywhere, here we can see on the pain complaints area, this person had reported pain in 9 out of 10 body areas. And we can see this corresponds on the left with a pain drawing that shows pain everywhere. One of the big advantages of this approach is that it uses numbers, and this lends itself to mathematical modeling. With a pain drawing, you kind of eyeball score it and say, well, this looks anatomical and this doesn't. With mathematical modeling, however, you can use a variety of methods to make predictions. Now here we can see we can use these numbers to predict a diagnostic category. Like in this case, a particular patient had a 94% match with back injury, and a 77% match with neck injury. If we compare this approach to pain drawings, this approach is much faster to administer and score. It only takes the patients a couple of minutes to do this, and scoring is computerized. In contrast to pain drawings, who really takes time to ever score those? The reliability is very high. There are norms. This correlates with scored pain drawings about 0.70. Predicts diagnostic category correctly 82% of the time. This is the injury diagnostic category. So this was one of the ideas we were toying with as we were developing the BHI and BBHI. Here's another problem we ran across, which we'd really never thought of before. Once we'd asked people about pain in a bunch of different body areas, next question is, how do you come up with a total score? Now consider this question. If you have a back pain of 7 and a headache pain of 3, what would your overall level of pain be? It turns out there's this phenomena that we call the pain math. That some people would say a 7 and a 3, I'd say that my average would be a 5. Some people would say 7 and a 3, that's a 7. Some people would say 7 and 3, that's a 10. Now what's interesting is that personality traits influence pain math. For example, borderline personalities are more likely to say they have a pain level of 10 than people without borderline personality traits. Now just because you thought 10 in your mind doesn't mean you're a borderline. That's just one of the factors that goes into this. But it turns out that there's a whole range of pain cognitions that we hadn't ever thought of when we were exploring this. Another thing we looked at was how people tolerate their pain. People use pain numbers in all different ways. So if a person says my pain level is 7, what does that mean behaviorally? To try to address this, we invented a concept we call the pain tolerance index. Now this will take just a little bit of explaining. First of all, what we did is we were asking people about their highest pain in 10 different body areas, and from that we determined what their highest pain was. Now maybe there's a back pain patient, but they occasionally have headaches. If we look at this drawing here, we can see that a patient has more or less constant back pain, which is described in a dotted line, and intermittent headaches, shown by the black line, which varies quite a bit. But overall, in the last month, the worst pain was a headache, not the back pain. That worst pain became what we call the peak pain level. Now we asked them another question, which was, how much pain can you tolerate and still work and get on with your life? That's what we call the maximum tolerable pain. Now suppose a patient says I have a pain level of 9, and the maximum pain I can tolerate and still work is a 5, then that means the patient would have to reduce their pain by 4 points in order to work. That correction, in this case -4, is what we call the pain tolerance index. How much must the pain change in order to be just tolerable? The pain tolerance index was our attempt to tie the subjective world of pain experience to the outer world of disability behavior. In the upper corner here you can see a little graphic depiction of PTI distribution, which interestingly in the studies we have run so far has always appeared to be bimodal. We have one study under review which looked at PTI and other measures of pain and found that PTI was more predictive of adverse outcome than any other pain measure with regard to function, quality of life, depression, and anxiety. So this is a very different dimension of the pain experience. Let's give 2 examples because it's a little bit hard to get. So first example, a patient says my worst pain is an 8, but I can work with an 8. It's a PTI of 0. The patient is saying my pain is just tolerable and I can tolerate it without behaving in a disabled way. That's his cognitive prediction. On the other hand, you have a patient who says my worst pain is a 5, but I can't work at all unless my pain is 0. In this case, a PTI is a -5. So in this case, using PTI, even though the second patient has pain of 5, which is less pain, you'd predict more disability behaviors based on their PTI. Now, some of the work we've done with Pearson has focused on trying to apply good science to the assessment of patients with pain. Recently, though, we just published a paper trying to take a broad look at all the variables for patient selection. In this paper, we reviewed the literature on psychosocial predictors of surgical outcome, looking both at empirical studies and also expert opinion. We thought the expert opinion was important because, as we noted with Boer, all the research we have on surgical outcome is focused on mild to moderate psychosocial risk factors of certain types, and so it's quite limited. Consequently, we also thought it was important to include expert opinion about the impact of severe psychopathology on surgical outcome. From this review, we identified what we called the Convergent Model, which we used to convey our belief that the research and expert opinion seem to be converging on a set of psychosocial risk factors that should be assessed prior to invasive treatments, such as surgery or pain implants. Once we identified these risk factors, we used a standardized method which employed national norms to calculate risk scores. Now, we also addressed something which I don't believe has ever been addressed before, which is what is the reliability of a pre-surgical psychological evaluation? We calculated this on a group of 82 patients who went through this evaluation twice and produced reliabilities ranging from 0.85 to 0.91. The convergent model included two risk scores, what we called an exclusionary risk score. This assessed extreme risks like psychosis, suicidality, homicidality, and so on. Exclusionary risks are all signs of extreme psychopathology, any one of which might preclude a person from an elective surgical procedure. One of the things that got me thinking about exclusionary risks was a story that I often tell, is that I have a patient who came into my office about 20 years ago, drunk and firing his pistol, saying that he was going to kill his surgeon and kill himself. But during the whole process was also saying that he wanted some surgeon to fix him. Now, in my way of thinking, just a bad candidate for surgery. He's just too emotionally unstable. This person would never make it into an RCT. Now, in contrast, we have what we called cautionary risks. These were the things you often think of: depression, anxiety, somatic complaints, job dissatisfaction, and so on. Another way of thinking of it is that these are red flags and yellow flags, with the exclusionary risks being the red flags, cautionary risks being the yellow ones. In our study, we found that these risk factors did not only predict the outcome of spinal surgery, but other treatments as well, like upper extremity surgery, head injury rehab, work comp patients, acute PT, chronic pain, and injury litigants, which makes sense. If a patient is imminently homicidal, you'd think that interfere with compliance with most everything. So to our knowledge, this is the first study that's tried to take this criteria and apply it to other patients who are not just spinal surgery patients, but who are in other treatment settings as well. Now, the convergent model can be assessed using various tests, but in our own study, we used the BHI2 and BBHI2. These were the tests, as you recall, that we developed with Pearson. We've actually been working on these for about 24 years. In the last 17 years, I believe, with Pearson. In the fifth phase of development, we tested 2,500 subjects at 106 sites in 36 states. So this has been a long, arduous experience. In the attempt to address the needs in the field, our attempt was to produce a standardized measure that could assess patient, that could hold up to scientific scrutiny, that was normed, validated, and reliable. During the validation of the BHI2, we developed two main norm groups, which are patients in physical rehabilitation and community members. Both groups were obtained nationally and selected to match U.S. Census for gender, age, race, and education. We also used 8 comparison groups: headache head injury, neck injury, arm and hand injury, back injury, lower extremity injury, chronic pain, fake good, and fake bad. This whole process produced 2 tests: the Battery for Health Improvement 2, BHI2, which takes about 35 or 40 minutes, and the BBHI2, which takes about 8 or 10 minutes. Let's now return to Sarah and begin thinking about how we're going to assess her. At this point, though, Sarah's had more complications. Her infections has resolved as of her blood clots, but now, unfortunately, she's been determined to have avascular necrosis in her hip. She needs a hip replacement. It's not sure if it was blood clots or if her original injury somehow led to an impingement of a blood vessel in her leg, but somehow the blood flow to her hip was cut off and her hip joint died. Since the infection had resolved, though, she was now a possible candidate for lumbar fusion, so this was now back on the table. However, with the added setback of the avascular necrosis, Sarah continued to struggle with depression. Let's now talk about Sarah's assessment. It included a clinical interview, a consultation with a physician, a record review, and a BHI-2, along with other tests. Let's start by looking at Sarah's BHI-2 profile sheet. See, over here on the left side, we have 5 different groups of scales: validity scales, physical symptom scales, affective scales, character scales, and psychosocial scales. Across the top, you can see we have 2 different sets of T-scores. We'll come back to that in a minute. And the overall T-score profile. You can see the middle range here is average, between 40 and 60. Now, unlike on many tests on the BHI-2, both high scores and low scores are significant. And we use what's called a deviation bar chart. The length of the black bar corresponds to the Z-score. So the more a score diverges from the mean, either high or low, the longer the black bar. Now again, though, we have 2 different T-scores. You can see over here on the left the black and white diamonds with 2 different T-scores in that column. And on the black bar, we'll have a black dot and a white dot. What does that mean? Simply put, 1 dot out means this score is higher than that of a healthy person. 2 dots out means that this score is higher than that of a patient as well. Now let's just think about this for a minute. Suppose you on this side of the room are all people in the community, relatively healthy. Suppose you on this side of the room are all patients in rehabilitation. You're off of work because you've had an injury. Now let's compare my pain levels to both of you groups. Okay, compared to the average person in the community, I have more pain because I'm a patient, I'm injured. I'm in this group over here. Now compared to the healthy people, my score is significantly elevated. But compared to this norm group over here, patients, I'm more or less in the middle. On the BHI-2 profile, that means I would have 1 dot out. I am higher than the average healthy person, but I'm still average for a patient because all of us have patients are not doing as well as people in the community. But now suppose my condition gets worse. So now I'm even worse than the average patient. Now I have 2 dots out on the BHI-2 chart. My score isn't just higher than the average healthy person, it's higher than the average patient too, which means my score is really extreme. Looking back at Sarah's BHI-2 profile, we can see in some cases both dots are out, in other cases just 1. Now we're going to go through this one area at a time just to interpret what it means. Now over here on the right, we also see the percentile ranks compared to patients and their rating. And if all else fails, if this confuses you, then the rating will tell you what it means. You can see some of these scores are moderately high, which means it's high for a healthy person, but not unusually high for a patient. Next, we also have on the BHI-2 profile what are called content area scores, which are kind of like subscales. They work the same way, except they just have very low, low, typical, high, very high range, and the same band in the middle of scores. Let's look at Sarah's validity scores. On one hand, her self-disclosure score is in the average range, but her defensiveness is very low. This suggests she's presenting herself with a negative bias. Now, there are several explanations for this. Patients with low defensiveness are really making a point to say how bad their life is. Now, sometimes this is objectively true. It can also be seen as part of a cry for help. So you have to interpret this information in context. On the physical symptom scales, You can see that Sarah's functional complaint score is extremely high, the 98th percentile. Her somatic complaint score is high in the 90th percentile. What this means is she has extreme difficulty functioning. Remember, she has a herniated lumbar disc and needs a hip replacement. She can barely walk, and so this level of functional difficulty seems objectively true. Also high is somatic complaints. Now, in most scales, they call this somatization, but in reality, somatization scales don't measure somatization as described in the DSM-4. Rather, they describe a broad pattern of somatic complaints. Now, high level of diffuse somatic complaints can mean somatization. It can also mean the patient is having a really high level of stress-related symptoms. They may be sick or have medication side effects. We didn't want to call this somatization as we didn't want to presume that the only explanation was psychological. In Sarah's case, she did appear to have a lot of stress-related symptoms, but also some of her symptoms seem to be attributable to being on multiple medications and still recovering from the infection and other setbacks she's had. Now, notably, her pain complaint score is only moderately high with 1 diamond out, which is more than the average healthy person, but still in the average range for a patient. But let's look more closely at her pain complaints. This is the BHI2 pain analysis, and you can see here in the red are her pain reports, which are worse in her lower back area, also about her legs and feet, mid-back, but some in her arms and hands and head too. On the right side, we have the median pain reports of a national sample of patients with a low back injury, so we can use these as a basis for comparison. Also, she reports having a pain tolerance index of -4. She said she has a maximum tolerable pain of 5, with her worst pain being a 9, so she needs to reduce her pain by 4 points in order to be able to function. In the studies we've done so far, 4 points is still in the range where you can do something. Now, by way of comparison, do you recall that one patient who said his whole damn body hurts? Suppose you have a patient like that who has a pain level of 10 in 5 or 6 body areas and says he can't work unless his pain level is 0. This will produce a PTI of -10. Now, the odds of reducing pain of 10 occurring in 6 body areas to 0 is not good. The goal of treatment then is that with medications, to the extent possible, reduce the pain level, and with cognitive behavioral therapy and other treatments, as much as possible, improve the amount of pain she can tolerate. Now, if we look at how this all maps out, this matched with back injury 88%, and a lower extremity 61%, which fits. She has a hip injury. What's higher than I would have expected is upper extremity at 50%. When I asked her about it, Sarah said she'd been on crutches for so long that her hands and shoulders were starting to hurt. In the area of affect, Sarah's level of depression was higher than that seen in 96% of patients. But also note there are more than one depression measure on the BHI2, and this is why. One of the problems with assessing depression in medical patients is that many depression scales rely on physical symptomatology, such as loss of libido, weight change, and so on. Now the problem is when you have a medical patient who says, I'm tired all the time, I'm losing weight, I have no libido, and so on, is that a sign of depression or physical illness or medication side effect? You don't know, and because of that, on the BHI2, we separated out thoughts and feelings of depression, which is the depression scale, from physical symptoms of depression, which is the vegetative depression scale. You can see in this case, Sarah had high scores on both depression and on vegetative depression. Also, Sarah scored high on the BHI2 measure of suicidal ideation. This was a concern. On the printout, it also lists critical items. Life has been so hard lately that at times I've wished I were dead. Agree. I have attempted suicide in the past. Agree. It's also worth noting here that Sarah scored positive on the critical item for death anxiety, being afraid that she was going to die. Now, sometimes this can be seen in surgical phobias, but in Sarah's case, between the staph infection and the blood clots, there is some objective reality to this. I want to point out here, while we're looking at this particular slide, is that Sarah had average scores on compensation, focus, and entitlement. Now, sometimes people are looked down upon because they're in litigation, but what I've come to believe, it's not whether or not a person is in litigation, it's are they litigious. Sometimes people get into litigation through no fault of their own. And as we'll see in a minute, Sarah found herself in the middle of litigation for reasons that she could not control. Assessing depression is important in rehabilitation patients. First of all, review studies have shown that depression is a risk factor generally for a poor outcome from treatment. Other studies have also found that when you're depressed, you're less likely to adhere to treatment. For example, people who are depressed often forget to take their medications. Plus, if we apply the findings of Neuromatrix theory, people who are really depressed will probably complain more of pain. On characterological scales, Sarah had 2 moderately high scores. She could be a little bit dependent and needy, but not at a level that was unusual for a patient. There was also a slight elevation in substance abuse. If we look more closely at that, however, Sarah had a fear of becoming dependent on prescription medication. This also appeared to be based in reality. And as the months went by, she recognized that she was becoming more opioid dependent. Finally, if we look at the psychosocial scales, we can see a high score in 2 areas, one in family dysfunction and the other in survivor of violence. If we look at the content areas of family dysfunction, we can see family conflict is average, but lack of support is very high. So it wasn't open conflict, it was just no support at home. Survivor of violence is a scale which assesses a past history of traumatic experiences. You can see in this case, we can go to critical items, which show that in the past she's reporting that she's been sexually assaulted, and when she was a child she was molested. Now, it's not clear if these are referring to the same thing or different things. Later I asked her about this, and she revealed that in her teens she was sexually assaulted. She reported becoming very depressed after this, suicidal for a while, but saw a psychologist, did some good work and got through it, and really hadn't suffered from depression since that time. Even so, those were very painful memories for her. So overall, if we step back, what are the overall risk scores for Sarah? Using a Boer system, she had about 4 out of 9 risks. And I say about 4 because Boer really didn't supply any specific method or cutoffs for deciding what constitutes a positive score, and also you don't know how many risk factors is high, but 4, maybe 5 out of 9 Boer risk factors. On the Convergent system, there was one exclusionary risk factor which was on and off. Sarah had some suicidal ideation, and so at times this bordered on being an exclusionary risk factor. Other than this one potential red flag psychosocial concern, there were 7 of the yellow flag cautionary risk factors. This placed her at the 75th percentile rank. So using this system, we can at least get some kind of standardized measure of what her risk level is. This assessment also showed some positive signs, which is her pain and pain tolerance were still in the normal range. There was a general lack of characterological risk factors. There was no past history of substance abuse. And while she was in litigation, she was not litigious. Treatment implications. I referred Sarah back to her treating physician for consideration of medications. I also discussed with him how we needed to think about her dependence on opioids and how we could best deal with that. I often start with a relaxation and sleep hygiene training, followed by treatment for pain and depression. I think in treatment it's important to be mindful of the past history of trauma and also focus on problem solving with just trying to figure out what she needs to do now to get through life. If we think about these areas one at a time, first of all, there's a lot of reasons for treating depression. Besides Boer's study showing that is associated with a poor outcome from surgery, poor outcome from other treatment, increased pain levels, and poor treatment adherence. I think it's interesting to note that patients who are depressed often forget to take their medications or just don't do the things they need to do to get better. They just don't have the energy. If you look at medications, what road do we take? Now, some of you may be prescribing psychologists. I'm not. Although I try to stay up on the research on this, because physicians often ask me, well, what should I do? There's a recent really good article, 2009 by Cipriani. It was a meta-analysis of the various new antidepressants. Interestingly, I found perhaps the most efficacious one is Remeron, although the problem is it also has high side effects. Overall, they thought the two best medications were Lexapro and Zoloft, both because they were effective and well tolerated by most people. But they gave the edge to Zoloft because it's much cheaper now that it's generic than Lexapro. So that might be, just based on the literature, a good medication to start with. So while at the outset, I often refer patients for medication, where I start typically is with arousal. By this, what I'm referring to is what is commonly called the fight or flight response or the general adaptation syndrome. But from a more biological perspective, we're talking about the HPA axis, the interaction of the hypothalamus with the pituitary and adrenal glands. If we think of this generically as a stress response, there are a multitude of studies showing that stress can increase the risk of infectious disease, even to the point of increasing the risk of mortality. There's also research showing that HPA reactivity is associated with delayed wound healing. There are a number of interesting studies showing, for example, that when you actually create an experimentally induced wound and then compare patients who are experiencing a high level of stress versus low, that the people with a high level of stress have wounds that close more slowly. Now, what's really interesting is that we find that individuals as adults who years ago were abused in childhood tend to have stronger HPA reactivity. Somehow we see biological stress in childhood leaves a physiological imprint on a person. Now, why should this be? Let me take a moment just to explain the way I look at this. If you go to a gym and work out, your muscles get bigger and stronger. Similarly, if in childhood you exercise your stress response a lot because you have a stressful environment or a battering father, your stress response gets bigger and stronger. You develop a stronger fight or flight response. This has survival value. If you live in a dangerous environment, you develop a stronger fight or flight response, so you're better equipped to fight or run away when danger happens. It helps you to survive. Of course, the emphasis then becomes survival from short-term threats at the cost of this chronic hyperarousal, which means you may not live as long because your tachometer is constantly up too high. This is part of the wisdom of the body. What that means, though, is that, as this research has shown, individuals abused in childhood have stronger HPA reactivity, have a physiologically stronger stress response, and may respond differently as a consequence during the recovery process. Now, what I think is really amazing is that history of abuse or trauma can actually alter gene functioning. And this is, I think, astounding research that's been done in the last few years, showing that abuse and trauma can lead to epigenetic modifications to your DNA, and that these changes can be passed on to your offspring. What this is telling us is that abuse and trauma has a far more profound physiological impact than we'd realized previously. And it leads to a really interesting proposal about a new syndrome, the spite then fight syndrome. This refers to a previously unknown mechanism, which is that if you spite the mother, she will tend to tweak the DNA of her offspring to make more aggressive offspring, which will in turn protect her. So this shows a transgenerational aspect of stress, which is only recently come to light. And as you recall, Sarah had a past history of trauma, so you have to think about her psychophysiological reactivity as possibly being influenced by this. Another thing to think about is that wound healing is modulated in part by human growth hormone that's needed for bone regeneration and wound healing. But the highest levels of human growth hormone are released during deep sleep. When you're suffering from hyperarousal, though, you don't sleep deeply. You toss and turn, maybe get a lot of stage 2 sleep, but not the solid log stage 4 sleep. So one of the things I look at is sleep hygiene training. A recent review in the New England Journal of Medicine called Behavioral Approaches to Insomnia the Gold Standard. Now, the elements of sleep hygiene it recommended was restricting intake of caffeine and alcohol, increase in activity during the day, have a relaxation time before bedtime, get up at the same time regardless of how you sleep, and no naps, plus some type of meditation or rather relaxation training. In a study published just this year, they compared cognitive behavioral therapy and Ambien for the treatment of insomnia. What the study showed was, first of all, CBT was effective for insomnia by itself, and that for acute patients, adding Ambien to CBT made things better. For chronic cases, however, adding Ambien to CBT made it worse. So this suggests that using Ambien or other medications in the short term might be helpful, but this raises questions about the long-term use of medications for insomnia. Now also, during treatment, we use CBT for pain. There's a couple of approaches I really like. One is the book by Bev Thorne, which is CBT Method for Therapists. And the other is a patient workbook by Caudle, Managing Pain Before It Manages You, which was just recently released in its 3rd edition. That's a book that patients seem to find really helpful. Let's return to Sarah's case. Next, there are more complications, but this time they were legal complications. During her first injury, Sarah's insurance company is one we'll call Riscodyne, not their real name, but we'll call it Riscodyne. When she was injured for the second time, however, her employer had changed insurance companies to a company we'll call Caregiver Mutual. During her evaluation for the second surgery, her surgeon made an observation that he thought there really wasn't a second injury. It was just a flare-up of the first injury. As you recall, the first time she had a serious slip and fall, banged herself up pretty good. The second time she just bent over. So again, the surgeon says this really wasn't another injury. It was just the first injury had never totally healed. And that was evident on the imaging. This led to a problem of apportionment, which is to which company should these medical costs be apportioned. As a result of this, all 3 insurance companies now refused to pay for her care. The caregiver said, wait, if there was no second injury, then we're not responsible. It was the first injury. It's Riscodyne's job to pay for this. Riscodyne says, there was a second injury, and we're not responsible for it. They went beyond this to say that also we're not responsible for the depression because they found records of her being treated for depression 20 years ago and said, there, it's pre-existing, not our job to cover it. And her own private insurance, we'll call it Purple Cross, said this is clearly a work injury, thus it's not covered under our policy. So 3 insurance companies, none would pay. Sarah's case now came to revolve around a matter called legal apportionment. Now, apportionment refers to this idea of how much of a psychological or medical condition can be attributed to a particular cause. So now the focus became causality. I have a little graphic here that I wanted to show you, but I'm not really going to go too far into forensic matters. But basically, we can conceptualize a condition like this. There can be predisposing causes, a precipitating cause, and also sustaining causes. In Sarah's case, she had some degenerative disc disease that was a contributing factor. She had a past injury, which was the first injury. In this case, the precipitating cause was that she bent over. That precipitated the changes in symptoms. And then sustaining causes. She has a herniated lumbar disc. she can't get treatment, and she's depressed. So the question here legally is, how can you analyze all these causal factors and figure out how to apportion the causality, and from that, who's responsible to pay? Understanding causality isn't just important legally, it's important clinically too. If you're treating depression, for example, in this case, how much of Sarah's depression was from her pain, from the litigation she was trapped in, or from her past abuse? Could some of that depression been attributable to that? Depending on what is causing your depression, you might approach it differently. Next event is there was a court hearing in which Sarah was asked to testify about her depression. The risk-of attorney really aggressively cross-examined her about her past history of abuse, and Sarah just basically said, "You have no right to do this. I haven't been depressed for 20 years. This is none of your business." She really felt that the cross-examination was abusive, and so she refused to answer some questions. But when she did that, the judge told her, well, if you won't answer these questions, then Riskodyne can establish causality, and they don't have to pay. This was extremely disheartening for Sarah. Now, I later responded to this, and actually when we developed the BHI, we were actually thinking about this kind of scenario. Now, we have some kind of unusual subscales on our depression scale, one of which we call grief depression. And this is one of the perhaps most misunderstood little measures on a test. Like, why grief depression? That seems odd. What this measure attempts to assess is the sad feelings that arise in response to a loss of health. People will say, geez, I can't play ball with my kids anymore. I can't go for bike rides. I can't play softball. I can't go hiking in mountains. It's sad feelings in reaction to a change in health. As opposed to other scales here, which are more about depressive cognitions and sad feelings in general. We added this little scale to address matters of apportionment, which is to say, okay, this person is depressed for various reasons, but in Sarah's case, obviously, a strong component of the depression was due to her perceived changes in loss of health. And that was one of the things we used to counter Riskodyne's argument. Later, in another hearing, there were 6 experts, all medical experts, that all opined that there wasn't really a second injury and that Riskodyne should be responsible, including Riskodyne's own experts. Riskodyne, however, refused to accept this, and when the judge ruled against him, they appealed. Following this, caregiver sued Riskodyne, which makes Sarah the main witness, as if her life wasn't stressful enough already. Now she's caught between 2 litigating corporations. Now, during this process, her treatment stops because nobody's going to pay. Her surgeries are delayed for 18 months. During that time, she becomes opioid dependent. Between her hip and her back, she can barely walk. She's severely depressed at times, gains 50 pounds. This further adds to her depression. Also, from using crutches for 18 months, she develops carpal tunnel symptoms in her hands. When her medical bills aren't paid, various parties turn her into collections. So now she has bill collectors calling. She later tells me that she's doing okay, but she really is afraid of continuing medical care for fear of getting further into debt. To make matters worse, with her disability pay cut off, she faces the prospect of being homeless, and her husband, who is totally overwhelmed by all this, files for divorce and leaves. I had a number of rather terse exchanges with Sarah's 2 warring insurers, and to their credit, after a while, caregiver really came through. They said, even though all the experts say we're not responsible for this, we will pay all the bills and then sue Riskodyne to recover the costs. So, after that, treatment was restarted. She proceeded on with hip replacement, lumbar fusion, treating of carpal tunnel symptoms, eventually spinal cord stimulation, and throughout this psychological treatment for depression, pain, opioid management, and weight loss. During the cognitive therapy for pain, I thought Sarah proved to be remarkably resilient. I always enjoyed her ability to crack a joke or find some way to break away from the difficulty of her life. Eventually, she went on to have a spinal cord stimulator inserted. Now, if you're not familiar with this technology, it involves inserting electrodes along the spinal cord, which can electrically interrupt pain signals and replace them with a tingling sensation. Like most people, Sarah found this especially effective for the pain radiating into her legs, somewhat less effective for the pain in her back, but at least it offered her some relief for which she was grateful. The final court ruling. Riskadine loses on all counts. They're ordered to pay all medical costs, all mental health costs, 18 months wage reimbursement, lifetime maintenance care. I mean, overall, this was a total loss for Riskadine. Who knows what it cost to have these 18 months of litigation, with all the attorneys involved making $300 an hour, not to mention that Sarah's condition was more difficult to treat because of the delays. So, what was the outcome of all of this? I had the opportunity to speak with Sarah about 8 years after her injury. She had been out of treatment for quite some time. She still had chronic pain, but was much more functional than she had been when we first met. She was generally in a good mood, wasn't depressed, and wasn't taking antidepressants. She was also coping with her pain without opioid pain medications and was glad to be off of those. She had coped with her divorce successfully and had found a supportive relationship that she was in, and she had begun putting her life back together. At the time we spoke, she was unemployed, but she was hoping to find work. She felt with the right kind of job she could work, but she did have significant physical limitations. In retrospect, had Sarah gotten timely treatment, her outcome probably would have been significantly better. In conclusion, injury and chronic pain are often very complex biopsychosocial phenomena, which can be further complicated by legal matters and by administrative questions such as apportionment of causality. Within this context, psychological assessment can play an important role in both the development of treatment plans for these complex patients and with addressing forensic issues that arise. And lastly, psychological treatments are critically important components in a treatment plan for patients with chronic pain, as can be seen in this case. As often, it's not just the injury itself, but the way that a patient's injury can spiral out of control, creating an enormous number of psychosocial complications that have to be addressed in order for the patient to recover. For further information, this case study was published previously, which will supply some additional detail.